So, good evening, everyone. I hope I am audible and visible. So, everything fine? Am I audible? Yes, Sujit Kumar. Hello. Good evening. I hope everything is fine. So, today we are going to discuss about physiology of diabetes and its clinical applied. What are the things that can be asked in your examination in your form of MCQ as well? Just a minute, let me see. Okay. So the content, what we will discuss in this 45-minute or 1 hour, it is overview of diabetes, a brief pathophysiology and complication of diabetes, treatment guidelines, oral anti-diabetic drugs, insulin therapy as well as combination therapy. Okay. So this will be our content today. So overview, something about the history. So before insulin was discovered in 1921 by Best and Banting, we know that everyone with type 1 diabetes died within weeks to years of its onset. Okay. So when we don't have insulin, so if someone come with type 1 diabetes, but after that, it was a revolution, because after that, after diagnosis, you can see if you are giving the insulin, patient become like this. So it was really a wonderful discovery. Okay. Now diabetes mellitus literally means what? Sweet siphon. Diabetes means siphon. Mellitus means sweet, because of the taste of the sweet taste of the diabetic urine due to excess of sugar. So initially they were not knowing the pathophysiology. They simply noticed that urine was having sugar in it. So they named it diabetes because there was a polyuria, because of the symptom polyuria. So they named it diabetes mellitus. Okay. So in physiology or in medicine or in pharma, these lines are from Goodman and Gilman, the pharma book. What is diabetes? Okay. So diabetes is a spectrum of metabolic disorder arising from various pathogenic mechanism resulting in persistent hyperglycemia. Persistent. It should not be on one occasion. It should be persistent because of various pathognomic mechanism. There are multiple pathology. So not a single pathology, there are multiple pathophysiology which is causing the diabetes. And what is that called as? That is called as omnus octate. Okay. So there are various risk factors. For example, non-modifiable. It will come after certain age. You cannot modify the age. You cannot modify the gender. Yes, good evening, sir. Good evening, Raju Dhawan, sir. Thank you. Okay. And also the genetic predisposition. Then there are some modifiable, for example, obesity, especially the visceral obesity, the central obesity. It is causing insulin resistance. Then the sedentary lifestyle, stress, smoking and alcohol. So these we can modify. Okay. Now, what is the ominous octate in pathogenesis of type 2 diabetes mellitus? Ominous octate. So not a single pathophysiology. There are 8 pathophysiology we can say for diabetes mellitus. So number 1, decrease insulin secretion. Okay, of course we know there is decreased insulin secretion. We know that. But not only insulin secretion is less, more important is that there is decreased insulin function. Okay, so that is causing increased glucagon secretion. So on one hand, see, insulin is the only hormone in our body that is hypoglycemic. The only hormone in your body that is hypoglycemic is insulin. Rest all cortisol, growth hormone, epinephrine, glucagon, all are hyperglycemic. So there is a balance. As insulin becomes less, it causes hyperglycemia. So not only decrease in insulin secretion, but also increase in the glucagon secretion can cause pathogenesis of the type 2 diabetes. Then increase hepatic glucose production by gluconeogenesis, by glycogenolysis, whatever may be the mechanism, but glycogen is converted into glucose, proteins are converted into glucose. So there are various mechanisms by which glucose can become more in your body. Decrease incretin effect. Now what is incretin phenomena? What is incretin phenomena? See, just tell me one thing. You can answer me. Welcome Dr. Devasis. Welcome Yuvraj. Okay, thank you. So decrease incretin phenomena. What is incretin phenomena? I will ask you a question. If I give oral glucose or IV glucose, in which condition release of insulin will be more, oral or IV, and why? Who will tell me? If I am giving oral glucose and also I am giving IV glucose, what do you think release of insulin will be more? In which condition, oral glucose or IV? Yes, definitely you are true. It is oral glucose, because when we take food orally, K cell of the intestine and L cell, they releases a hormone called as GIP and GLP, and they act on the beta cell. They act on the beta cell to release insulin. So this is called as incretin phenomena or incretin effect. So due to some pathophysiology in intestine also, or some other cause, there will be decrease in incretin effect. There are ominous octet. There are 8 pathophysiology. Okay, 8 pathophysiology. So not a single pathophysiology for diabetes. That is why there are multiple drugs acting on various pathophysiology. Then increase lipolysis due to some condition. If there is more conversion of fat into the glucose, it can also cause persistent hyperglycemia. Okay, then increase glucose reabsorption. You know, in kidney there is SGLT1, there is SGLT2. These are reabsorbing the glucose, and if this reabsorption increases due to any pathophysiology, it will again increase the level of glucose in the blood. It can also cause persistent hyperglycemia. Then glucose uptake will decrease in the muscle. You know that glucose uptake is by glut. Which glut? Glut 4. Glut 4 is helpful in taking glucose from the muscle as well as from the adipocytes. So if there is decreased glucose uptake. Good evening Rizwan, good evening. So there are neurotransmitter defect also. So remember, there are 8 pathophysiology, not a single. It is called as ominous octet. What is it called as? It is called as ominous octet. Okay. Now question. Diabetes mellitus is a disorder of hyperglycemia. Which of the following is not common characteristic feature of type 2 diabetes mellitus? Impaired insulin secretion, increased insulin resistance, diabetic ketoacidosis, or excessive hepatic glucose production. What do you think is the correct answer? I mean, which is not that common in diabetes. What is the answer? Impaired insulin secretion. Is it the pathophysiology in diabetes? Increased insulin resistance, then diabetes ketoacidosis, and also excessive. Good evening Kuldeep, good evening Ankit, everyone. Yes, excessive hepatic glucose production, diabetes ketoacidosis, increased insulin resistance, or impaired insulin secretion. What do you think is the correct answer, which is not common characteristic in type 2 diabetes? Type 2. What is the answer? Yes, A. Impaired insulin secretion. Diabetic ketoacidosis. Okay. Diabetic ketoacidosis is not common. Okay. It is rare, and that too in type 1 diabetes. Type 1 diabetes when insulin is absolutely absent. Isn't it? Impaired insulin secretion. Yes. Good evening Rama. Increased insulin resistance, of course. Excessive hepatic glucose production, of course. So which is not common? What is the answer? Answer is diabetic ketoacidosis is not common, of course. Of course it is a complication. It is a complication, we know that. But it is not a common characteristic. Question is about the characteristic. Okay. Now let me move further. A 30-year-old nursing student present with confusion, sweating, hunger and fatigue. Blood sugar is 40 milligram per deciliter. Blood sugar is 40 milligram per deciliter. Patient has no history of diabetes mellitus, although her sister is insulin dependent diabetes. The patient has several similar episodes over past year, all occurring just prior to the reporting for the work at the time of hypoglycemia. The patient is having high insulin level and low C-peptide. What is the most probable diagnosis? What is the most probable diagnosis? Okay, no problem. If insulin level is high, see, in the case patient is coming to you with hypoglycemia, and when you suspected, it can be insulinoma, it can be whatever, okay, but the C-peptide level is low. So in those conditions, if insulin is high but C-peptide is low, yes, medical student, factitious hypoglycemia, your answer okay. What about others? Reactive hypoglycemia, pheochromocytoma, insulinoma or sulfonylurea use. If you know the structure of pre-pro-insulin, then your answer will be correct. Yes, Indra Reddy, C. Factitious hypoglycemia. Okay. Please everyone answer. It can be correct, it can be wrong, but please try to answer. If you answer, it can be corrected also. What is the answer? Dr. Mukesh, C. Okay. Let everyone answer. Don't hesitate in answering. The main condition is that patient is coming to you with hypoglycemia, sweating, confusion and all those. Now you are checking about the insulin because there can be so many diagnoses. Good evening, Arya. Yes, what is the answer? Most of you, by the way, are correct, I must say. Very good. Answer is factitious hypoglycemia. Yes, very good. Why? See, you must understand the diagram, the image. What is this structure called as? This is your initial segment. This is your initial segment. This is chain A, chain B and chain C. This is your disulfide bond and this is called as pre-pro-insulin. What is this called as? Pre-pro-insulin. This is the exact form of pre-pro. It is not insulin. Okay. But after removal of initial segment, there is A chain, there is B chain, and there is C chain. It is called as, what is this called as, doctor? Tell me. Pro-insulin. It is called as pro-insulin. That was pre-pro-insulin. But after the release of C-peptide, okay, you have A chain and B chain. This is called as insulin. This is called as insulin. So whenever insulin are released in your body, equimolar amount of C-peptide is released. See, this is very, very important for forensic point of view, for physiology point of view, and for medicine point of view. If you are checking the insulin level, always they are equal. Insulin and C-peptide both are always equal. It cannot be that less insulin is more, C-peptide is less, or one is more, one is less. So if someone is taking insulin from outside, in that condition, insulin will be more, C-peptide will be less. So please try to understand this point, that whenever insulin is endogenous, okay, C-peptide is equal to insulin level. But when we are taking insulin from outside, so in this patient, if you see that her sister was type 1 diabetes, she might be taking the insulin. So for some sympathy or whatever, she might have taken the insulin and, posing that I am having hypoglycemia, I should not go to my college or I should not perform my duties. So some factious cases also come to you. It is not insulinoma. It is not insulinoma. Why? If it is the tumor of insulin, okay, the number of insulin as well as C peptide both will be what? Equal. But in the question, high insulin level and low C peptide level. High insulin level and low C peptide. It is also not sulfonylurea. If someone is taking sulfonylurea drug, glimepiride, glipizide, okay, glibenclamide, in that condition also, these sulfonylurea act on the beta cell to release insulin as well as C peptide. So in all other condition, reactive hypoglycemia, in all other condition, you must remember that if it is endogenous, C peptide will be equal. Okay. Now how to make diagnosis? How to make diagnosis? Some patient coming to you that this much is sugar, this is my fasting sugar. So when you will say that patient is diabetes, what is the criteria, ADA criteria? Number one, fasting blood or plasma glucose should be more than 126. So what is the first criteria of diabetes? Fasting plasma glucose should be more than or equal to 126 milligram per deciliter. Number one. So either you are getting at one occasion fasting blood glucose to be more than 126, or if you do 2-hour test, postprandial test, and if it is more than 200 milligram per deciliter, okay, during OGTT, okay, test is performed after giving 75 gram anhydrous glucose dissolved in water, and after if you do OGTT, it is more than 200, we say patient is diabetes. Or if you are measuring HbA1c, okay, if it is more than 6.5 or equal to 6.5%, then again we can say patient is diabetic. First we must know how to label a patient as a type 2 diabetes or type 1 whatever. So what is the criteria of diabetes? These three are criteria when you can label a patient with diabetes. Or one more last, if patient is having characteristic symptom of diabetes like polyuria, polydipsia, polyphagia, as well as random plasma glucose to be more than 200, this is also a case of diabetes. So please remember the diagnostic criteria. Now comes question, which of the following is not criteria for diagnosis of diabetes? What is the answer? Fasting blood glucose more than 126 milligram per deciliter, 2-hour postprandial glucose more than 140 milligram per deciliter, HbA1c more than 6.5%, or random blood glucose more than 200 milligram per deciliter with classical symptom, which is not the criteria. What is the answer? What will be the correct answer? Yes, Kuldeep Singh, 2. I mean, you mean B, okay? So what is the correct answer? Okay, so most of you are correct. So now we know, now we have to remember fasting blood glucose more than 126 milligram per deciliter. Very good. So what is wrong in that? 2-hour postprandial glucose more than 140. This option is wrong. So what is the correct option? It should be more than 200 milligram per deciliter for making the diagnosis of diabetes mellitus. HbA1c more than 6.5, absolutely correct. Random blood glucose more than 200 with classical symptom, absolutely correct. So which option is wrong? Option number B. What is wrong? It should be more than 200 milligram per deciliter. Now these are the tools. Now if we see the complication of diabetes, acute can be diabetic ketoacidosis, DKA, which is more common in type 1 diabetes. In type 2, complication is different. I will show you in the MCQ form. Chronic can be microvascular, can be macrovascular. In the macrovascular, it can be retinopathy, problem with the retina, nephropathy, neuropathy. In macrovascular, it can be myocardial infarction as well as a stroke. Okay. So can anyone tell me what complication is more common in type 2 diabetes? Who can tell me the answer? In type 1, DKA is more common, of course. What is more common in type 2 diabetes? Who is going to tell me this answer? Most of your answers are correct. Good. Yes, Vikas Jadhav, future doctor, tell me the answer. What is more common complication which is acute in type 2 diabetes? It is not DKA, it is something else. And they are asking repeatedly this question in your exam to differentiate between DKA and the second complication. What is that? Nephropathy doctors, they are chronic complication. I am asking about the acute. Which complication is more common in type 2? And that is acute. Okay, that will be clear in the next MCQ. This MCQ will help you in clearing the question. A 50-year-old obese female is taking oral hypoglycemic agent. While being treated for upper respiratory infection, she developed lethargy and brought to emergency room. Neurological examination is non-focal. She does not have neck. Yes, Indra Reddy, you are correct. Neck rigidity. Lab reports are sodium, of course, you can see normal. Potassium, okay. Bicarbonate is almost, it should be 23, 24. Glucose 900 milligram per deciliter. 900 milligram. Okay. Creatinine 3, it is more, of course. HbA1c is 6.8, it is correct. BP is normal. Which of the following is most likely cause of patient coma? Why patient is in coma? Is it diabetic ketoacidosis? Is it hyperosmolar coma? Is it inappropriate ADH, SIADH, or non-compliance with medicine? See, forget the medication, or bacterial meningitis? What is the correct diagnosis of this question? Glucose 900, so much. Is it causing DKA? Is it causing hyperosmolar coma? Or what? This question will help you in differentiating the type 2 or type 1 diabetes complication. Is it DKA? Is it something else? Yes, Dr. Anubhav, you are correct. Okay, future doctor B, hyperosmolar coma. So can you tell me why it is not DKA? Why it is not DKA? Why it is hyperosmolar coma? What is the, most important point which you have noted here? Yes, Kuldeep Singh B, okay. So I hope you will not forget now onward how to differentiate. See, let me tell you. In type 1, see, there are two things. One is diabetes ketoacidosis. Other is hyperosmolar coma, which has more mortality. किसमें पेशेंट ज़्यादा मर जाता है? हाइपरऑस्मोलर कोमा में या फिर डीकेए में? Which has more mortality? DKA or hyperosmolar coma? Yes, anyone? See, in DKA, the center stage is what? Acidosis. Metabolic acidosis with high anion gap. High anion gap. What is the center theme? Or what is the center stage of DKA? It is acidosis. It is not hyperglycemia. It is absence of insulin. What is the most important point? If insulin is absent, then ketone bodies will be formed. Ketone bodies. See, try to understand the pathophysiology of complication. Only then you can understand the question. So in type 1 diabetes, the main problem is not hyperglycemia. Of course, hyperglycemia will be there, but not that much. Okay, high blood glucose is not center theme. Center theme is absent of insulin, because even if insulin is present in slight dose, it will always inhibit ketosis. Only when insulin is absent, ketone bodies start forming, and this started metabolic acidosis. So you will get the pH. Bicarbonate will be affected. Here bicarbonate is normal. Here bicarbonate is normal. Almost normal. In metabolic acidosis, bicarbonate will be more or less. It will be less. Isn't it? And it is compensated by respiratory alkalosis. Meaning what? Kussmaul breathing. Kussmaul. Why you get Kussmaul breathing in DKA? Because you want to release CO2. You have metabolic acidosis. And metabolic acidosis is always compensated by what? Respiratory alkalosis. Hyperventilation. You want to release CO2 to compensate the acidosis. So these are characteristic of DKA. This is the main pathophysiology of DKA. In hyperosmolar coma, center theme is what? Increase blood glucose. And the formula of osmolarity. What is the formula of osmolarity? Of course, it is 2 into sodium plus glucose upon, the formula? BUN upon 2.8, everything. So glucose is playing the role, but very little role. When glucose is normal, it is playing very little role. Main role is played by the sodium. But when glucose is very, very high, 600, 700, okay, then osmolarity will increase. And if you know the basic physiology, the general physiology, if osmolarity is increased, it will take away the water from the cell. Water move from low concentration to high concentration. Now, more glucose in the ECF. It will cause more osmolarity. So cell will start shrinking. All water will go from ICF to ECF. It will cause dehydration. So this is your hyperosmolar coma. So problem is dehydration. Not acidosis. So please try to let me summarize both, because multiple question can be asked to differentiate between DKA and hyperosmolar coma. It is more common in type 1. Why? Because in type 1 there are more chance of absence of insulin. Otherwise, if patient is type 2, he is taking insulin, he has avoided, he has not taken insulin, it can also cause type 1 DKA. Is this clear? So again, coming to the question, you can see here oral hypoglycemic agent. Bicarbonate is normal, but because glucose is 900, answer will be what? Hyperosmolar coma. Is this clear? Is this clear how to differentiate between DKA and hyperosmolar coma? This is okay. So now, treatment guideline. Okay, what is the treatment guideline? First is lifestyle modification. Second is oral anti-diabetic drug, and then combination therapy. So starting with the oral anti-diabetic drug. First I will tell you the category, then I will give you the physiology of that, how they are acting on the beta cell, then we will discuss the complication and side effect and all. Okay. See, in your NEETPG or NExT examination, plenty of questions are from diabetes, and they all are integrated. Even if they are asking you the physiology question, they will ask you integrated question. Okay. So the first category is sulfonylurea. Second is meglitide. Then it is GLP-1 receptor agonist like exenatide, liraglutide, semaglutide. All these are. Then DPP-4 inhibitors, gliptins, sitagliptin, vildagliptin, sexagliptin, elogliptin, linagliptin. Okay. And then to understand the pathophysiology and also the pharmacology of the drug, we must know how glucose cause release of insulin from the beta cell. This diagram is damn important to understand almost all the drugs which are used in diabetes. If you understand this diagram, you can understand the pathophysiology of diabetes also, and also the pharmacology of the drugs. See, this is the beta cell. Question number 1. Glucose enter inside beta cell by which glut? Which glut is present in beta cell? It is glut. It is glut 2. Glut 2 is in the beta cell, liver, intestine and kidney. Now, which channel is present on beta cell? This is your beta cell. Beta cell of the islet of Langerhans in the pancreas. The endocrine section of pancreas is called as islet of Langerhans. It is in the tail of pancreas where we have alpha, beta, gamma and all those cells. Now, which channel is present? The name of channel is ATP dependent potassium channel, and potassium keep on going out. Normally, from the beta cell, potassium keep on going out. Good evening. Okay. Now, when we take glucose, it come inside like this and it is converted into glucose 6-phosphate which form ATP by simple glycolysis. By simple glycolysis. Whatever food you take, it converts into what? Glucose. Glucose get inside beta cell and it is converted into ATP. Now this will close ATP dependent potassium channel. It will close ATP dependent potassium channel. Now this potassium will rise. And you know in basic physiology, when potassium rise, it causes depolarization which open voltage gated calcium channel. Now this calcium everywhere in your body, calcium is important for what? Exocytosis. So it will try to release the insulin. What are these? These are insulin. So this calcium will cause release of insulin and C-peptide. Clear? This diagram is very important. So whenever you take food, it is converted into glucose. Glucose enter inside the beta cell by glut 2, which convert into glucose 6-phosphate, which form ATP. Okay. Now this will close ATP dependent potassium channel. Potassium will cause depolarization, open voltage gated calcium channel, and this calcium will cause exocytosis of the insulin. This is normal physiology. Now coming to the pharmacology. Sulfonylurea act on sulfonylurea act on which channel? Answer is ATP dependent potassium channel. See, normally when you take food, only then insulin is released, so we don't have hypoglycemia. This is the wonderful mechanism of the God, of the nature, that whenever you take food, only then there will be release of insulin. But when you take sulfonylurea, Glipizide, Glipizide, whatever, it will act on ATP dependent potassium channel and it start releasing the insulin, and this excess insulin can cause, what is the side effect of this drug? It can cause hypoglycemia. It can cause hypoglycemia as well as weight gain. If you remember the basic physiology of insulin, there are two pathways. One is metabolic, other is mitotic. So metabolic pathway will cause hypoglycemia and mitotic pathway will cause weight gain. This is the reason sulfonylurea cause weight gain. Now, there is one more mechanism of release of insulin. There are serpentine receptor on beta cell where act 2 hormone. These two are incretin hormone. One is GLP-1, other is GIP. What is GIP? Can anyone tell me? GLP is glucagon like peptide. GLP is glucagon. It is glucagon like peptide. And what is GIP? It is not gastric inhibitory peptide. It was the older name. At that time, we were not knowing the function. We don't know. We thought that it will inhibit the motility of the stomach. But now we know it is an incretin hormone. And the new name is glucose dependent insulinotropic peptide. Insulinotropic tropic peptide. Okay, this is released from the K cell of intestine, and this is from your L cell. L cell and K cell. Okay, so K cell in the intestine releases GIP, L cell releases GLP, glucagon-like peptide, and these are GQ receptor. They will release the calcium and they will again cause release of insulin. So release of insulin is not only by ATP dependent potassium channel, but it can also be by incretin hormone. If you understand this diagram, only then you can understand all the pharmacology. See, let me explain you. GLP, this hormone, after the action is over, it is degraded by which enzyme? It is degraded by which enzyme? DPP4. Okay, so after the function of GLP is over, it will be degraded by DPP4. So काम हो गया, फिर उसको destroy कर देना. कैसे? By DPP4. After function is over, after the release of insulin. This is taken by your pharmacology people. They will inhibit this DPP4. Now comes the drug DPP4 inhibitors. From here comes the drug DPP4 inhibitors. If you inhibit DPP4, you are increasing the time of GLP, and GLP will act on beta cell to release more and more insulin. What a wonderful mechanism. So all the gliptins, all the sisters, sitagliptin, all gliptins, sitagliptin, vildagliptins, then allogliptin, linagliptin. There are plenty of gliptins. All gliptins are DPP4 inhibitors. Okay. Now I will ask you, which gliptin is kidney safe? Yes, Ritesh, can you tell me which is the only gliptin that can be given even if there is CKD patient? Otherwise, we avoid the drug. Yes, linagliptin. Every year they are asking this question in your exam. Linagliptin is kidney safe. Anyway, come back to the physiology. So we can see here, sulfonyl ureas are acting on ATP dependent potassium channels. So they are called as insulin secretagogue. Similarly, even gliptins, even GLP-1 agonist, they are also called as what? Insulin secretagogue, isn't it? Yes, in the Reddit, Tenli is there, but it is not FDA approved. It is used in India most commonly as well as Japan. But because it is not FDA, so I am not mentioning it. Tenligliptin is also there. Sitagliptin, vildagliptin, sexagliptin, these are FDA approved. Okay. Now come back to the category of the drugs. For example, anti-diabetic drugs can be classified into two categories. One I told you secretagogue. Okay. Second is, these are secretagogue. They enhance the release of insulin. For example, sulfonyl urea. Okay, like glibenclamide, glipizide, gliclazide, and glimepiride. These all are acting on which channel? Tell me, which channel? They all act on ATP dependent potassium channel. They act on ATP dependent potassium channel. Then meglitinide, then glucagon-like peptide. I have told you, GLP-1 agonist. We know the hormone GLP-1. So they are giving GLP-1 receptor agonist. They are mainly injectable drug like exenatide, liraglutide, semaglutide. Now one thing I want to like to add, initially they were not used more commonly because they are subcutaneous injection. But now semaglutide is used as oral also. This drug has come in the market in the form of oral drug also. This is the only GLP-1 receptor agonist that is also available in the form of oral. Otherwise, all GLP-1 receptor agonists are injection. They are subcutaneous injection. But semaglutide is the only GLP-1 receptor agonist that is also available in the form of oral drug. Then comes DPP-4 inhibitors. What are those? They are gliptins. Sitagliptin, vildagliptin, sexagliptin, alogliptin and linagliptin. Linagliptin is the only gliptin that can be given in CKD because it is not released from the urine. Okay, then there are few drugs that overcome the resistance of the insulin. Insulin act on which receptor? Receptor tyrosine kinase. We know that. Okay, so either you release more and more insulin so that patient can improve, or even if there is more insulin, they are not acting because receptor is resistant. So why don't you tackle the problem with the resistance, especially in Indians? See, what is insulin resistance? What is insulin? What is the physiology of insulin resistance? Whenever normal amount of insulin is doing subnormal action. Sometimes we have enough insulin, but receptors are not working properly. Why? Because of central obesity. हम लोग बोलते हैं कि यार मेरा वेट तो 70 kg है, हमको डायबिटीज़ क्यों हो गई? वेट 70 kg मगर जो टिमकी निकली रहती है आगे, दैट टिमकी, central obesity. Central obesity is dangerous, not subcutaneous. Fats can be below skin also. It can be subcutaneous also. But that is not bad. That is good fat. Okay. So if your overall weight is 100 kg, you are overall, it's okay. But even if you are lean and thin, but if you have tummy, that can cause insulin resistance. If you remember in biochemistry, we read that central obesity causes serine, threonine. It causes serine, threonine, phosphorylation of IRS1. It is question from biochemistry. What is the biochemistry of insulin resistance? It causes serine, threonine, phosphorylation of IRS1. So central obesity is bad. So in that case, which drug should be given? There are only two drugs that are sensitizer. Only two drugs are there that are sensitizer. One, biguanide, AMPK activator, metformin. It is the best insulin sensitizer. That is why it can also given in PCOD also when they have IR. Okay. Second is PPAR gamma activator, that is pioglitazone. So there are only two drugs, and especially in the Central Asia population, Indian population, we all have insulin resistance. So these two drugs should be used. Okay, metformin is must. Why? It is one of the best insulin sensitizer. I will discuss the mechanism also, but you must remember metformin and pioglitazone. So one category was Insulin Secretog. Second category was to overcome insulin resistance, and third category is miscellaneous. For example, to absorb carbohydrate, we need alpha glucosidase. So if you inhibit alpha glucosidase, carbohydrate will not be absorbed, glucose will not rise, and it is best drug for Indians. Why? Because our more of our drug is what? More of our food is what? Carbohydrate. Chawal aloo, roti, dosa. So everything is having what? Everything is having carbs. So we take lot of carbs. For that purpose, these are one of the best drugs, like acarbose, voglibose, okay, miglitol. So they are miscellaneous drug. Number two, SGLT2 inhibitor. If you remember that in physiology, in proximal convoluted tubule, if you remember, okay, glucose is absorbed from PCT by SGLT1 and SGLT2. Okay, 90% by SGLT2. So if you block SGLT, okay, then glucose start coming in the urine. So all gliflozin, dapagliflozin, empagliflozin, canagliflozin, remogliflozin, these all are SGLT2 blocker. Then amylin analog. We know amylin causes the increase in the glucose level, the rate of increase in the glucose level. Okay, that is governed by amylin. Okay, and the example is pramlintide. Then dopamine D2 receptor agonist like bromocriptine. They are miscellaneous drug. Okay. So as we know, drug treatment is based on two key category. One is that you have to tackle with the insulin resistance. Second, you have to tackle with the impaired insulin secretion. For resistance, we have to give either metformin, or you can use pioglitazone. Rosie is banned because of all the side effect. Impaired insulin secretion, we can give secretagogues like sulfonylurea, we can give gliptins, we can give GLP-1 agonist. Okay. Now drug reduce glucose by a few ways. We know that insulin secretion, and drug can target liver, pancreas, peripheral tissue and intestine. Now we have already discussed about sulfonylurea. It stimulates the insulin production in the pancreas. Glenide also stimulates. Bigonide, metformin. What metformin does? It decreases the glucose production in the liver. Number one. There are multiple mechanisms actually. One mechanism is it increases insulin sensitivity to the muscle. It is a good sensitizer. And second is that it decreases glucose production in the liver. Then alpha glucosidase inhibitor. It decreases carbohydrate absorption. Then your glitazones, they increase insulin sensitivity. SGLT2 inhibitor, they prevent glucose resorption from the kidney. DPP4 inhibitor, again amylin, reduces liver glucose production. Okay. Now the side effect. Bigonide, some people say that metformin decreases body weight. No, it does not decrease body weight. It is weight neutral. It neither increases nor decreases. Sulfonylurea, but the side effect of metformin are GI side effect, but contraindicated with renal insufficiency. Maximum dose is 2.5 gram, but we should not give in renal insufficiency patient, CKD patient. If EGFR is less or creatinine is high, we must avoid metformin. Then sulfonylurea is rapidly effective, one of the best drug. But the problem is that it causes weight gain. I have discussed that. Hypoglycemia, especially with glibenclamide. Glibenclamide causes serious hypoglycemia. Lot of mortality has been seen. So whenever you are prescribing sulfonylurea, we must always counsel the patient. Then thiazolidinedione like glitazone. We know PPAR gamma agonist. Okay, the side effects are fluid retention, ankle edema, especially the ankle edema, chronic heart failure risk, weight gain, bone fracture. In the older women, post-menopausal women, we should avoid. Excessive potential increase in MI, especially with the Rosie, but Rosie is banned. GLP-1 agonist, one of the best side effect is weight loss. Remember, only two drugs can cause weight loss. Normally patients are obese. And sulfonylurea increase body weight. Glitazones increase body weight. Insulin increase body weight. So drugs are increasing body weight. Patient will come to you कि डॉक्टर साहब आपकी दवा से मेरा वजन बढ़ गया है. What to do? There are only two drugs that decrease body weight, cause weight loss. One is GLP-1 agonist, other is SGLT2 blocker. One is GLP-1 agonist, other is SGLT2 blocker. Of course, lot of questions have been asked in NEETPG 2018. A patient of BMI 35 is coming to you. He is taking glitazone. Okay, you want to replace the glitazone. What is the best drug? Answer was canagliflozin, SGLT2 blocker. So the purpose is to decrease body weight. If you are giving SGLT2 blocker, why it is one of the best drug nowadays? First line therapy. Nowadays, some doctors are using metformin with SGLT2 blocker because it is decreasing body weight. The only side effect is that it can cause UTI or genital tract infection. You have to ask the patient to clean the genitals. You have to ask the patient to take more and more water, so complication will not be there. Then pramlintide, again weight loss. DPP4 weight neutral. Pramlintide, weight loss because it is not used in India till now, amylin analog, because it is subcutaneous injection. But two drug you must remember that decrease body weight is SGLT2 blocker and GLP-1 agonist. Is this clear? So bigonides stop the liver from making extra glucose when it is not needed. Okay, metformin, bigonide, it lowers glucose production by the liver and improves cell sensitivity to the insulin. Multiple mechanism, there are multiple benefit of metformin. It is not that there is single benefit, there are multiple. It is also decreasing the glucose production from the liver and also improve the cell sensitivity to the insulin. It reduces, I'm telling you again and again, it is on the best insulin sensitizer. So it reduces insulin resistance. Advantage, it is weight neutral or weight loss, sometimes weight loss also, but very, very less. If they ask you weight loss, mainly GLP-1 agonist, SGLT2 blocker. Metformin also causes weight loss, but it is very, very less. It is in grams. Can be used safely without causing hypoglycemia. This drug never causes hypoglycemia. The mechanism is like that. Okay, and has beneficial effect on CVD outcome, cardiovascular outcome, according to the result from UK PDS. It lower HbA1c level by 1%. What are the disadvantages? We should not use in renal dysfunction or kidney problem. If patient is having CKD, we should avoid. And this drug always cause GI distress, gastric bloating, and all those drugs. Sulfonylurea, we know that. Okay, clopramide, not used dot common. Glibenclamide, gliclizide, glipizide. It enhances the release of insulin from the pancreas by acting on ATP sensitive potassium channel. It reduces A1C by 1.5%. What are the advantages? Glucose lowering more rapid. So if you want to start, you can start with metformin and sulfonylurea, but maintenance is not as good. What are the disadvantages? The most deadly disadvantage is hypoglycemia. Okay, especially with glibenclamide. Hypoglycemia, weight gain. Okay, these are side effects. Now, alpha glucosidase inhibitor, you know that acarbose, voglibose delays carbohydrate digestion, reduces A1C by 0.1, 0.5 to 0.8. It is weight neutral drug. The main problem is GI distress. Glitazones, they are acting on PPAR gamma. Can anyone tell me PPAR alpha agonist? Which drug is PPAR alpha agonist? It is fibrate. PPAR alpha agonist are fibrate, clofibrate, gemfibrate, like that. And gamma is glitazone, pioglitazone, and which drug is alpha gamma dual agonist? It is saraglitazar. Okay. Now GLP-1, we have discussed about the incretin phenomena. No, nothing in that. Okay. Now we should discuss about this. All we have discussed. This is PCT. From PCT, glucose is absorbed, and if you block SGLT, it will cause glucose in the urine. So all we have discussed. Now coming to the insulin, table of insulin action. The basic should be clear. Very, very basic thing I will discuss. There are few fast acting insulin. Fast acting. Number one, regular. Onset is half hour to 1 hour. So as you give regular insulin, the onset will be within 30 minutes to 1 hour. And peak will be 2 to 4 hours. When it will be the peak? 2 to 4 hours. Duration is 6 to 8 hours. And appearance is clear. We must know because sometimes we mix. We must know regular insulin look like clear. Okay. Then Lispro, Aspart, and Glulicin, their onset is even less than 15 minutes. Just you take insulin and take the food. Otherwise it will cause hypoglycemia. And the peak will be 1 to 2 hours. Duration will be 4 to 6 hours. It is also clear. Intermediate acting, NPH. The onset is 1 to 2 hours. It is intermediate acting. So the peak will come 6 to 10 hours. And duration is 12 plus. So if you are giving NPH, you have to give BD dose, morning and evening dose. It is cloudy. NPH is cloudy. So it will give you a hint. Sometime in the question they will give the appearance is cloudy. You must be clear that it is NPH. Long acting, determinate or glargine. They are peakless, because onset is 1 hour and they are flat. It will take 12 to 24 hours. Even if you give one dose, it will be okay. Glargine has maximum T half, 24 hours. Now coming to the question, see the question and tell me the answer. Your patient is 48-year male with 4-year history of diabetes mellitus type 2. He is currently utilizing NPH insulin and regular insulin. Okay. 40 unit and 20 unit prior to breakfast. 20/10 unit prior to supper. His supper time usually variable due to new job and range from 5 to 8 p.m. It is not fixed. So in reviewing his glucose diary, you note very low reading, 40 to 60 during past few weeks at 3 a.m. 3 a.m. In the midnight, there is hypoglycemia. And in the morning, there is hyperglycemia. First of all, tell me what is that phenomena called as? In the midnight, patient is having hypoglycemia. And in the early morning, patient is having hyperglycemia. What is that phenomena called as? Dawn phenomena or Somogoi phenomena? Then I will come to question later on. Who will tell me what is this phenomena called as? If someone is having, there are two phenomena. First I will discuss the phenomena, then I will come to question. One is called as Somogoi phenomena. Other is dawn phenomena. What is that? Dawn phenomena? See, let me tell you. In Somogoi phenomena, you take so much insulin. So much. Remember, Somogoi, so much. That at 3 a.m., patient is having hypoglycemia. If you take more insulin at night, due to any cause, at night there will be hypoglycemia. And in the early morning, there will be reactive hyperglycemia. Why? Due to other hormone, I have told you. The only hormone that is hypoglycemic is insulin. Rest all are hyperglycemic. So if at 3 a.m. there is hypoglycemia and early morning hyperglycemia, it is called as Somogoi. In dawn phenomena, you take down less insulin. So at 3 a.m. there will be hyperglycemia, and in the early morning also there is hyperglycemia. So what is the answer? In this patient, at 3 a.m. there was hyperglycemia. See, early morning both are having hyperglycemia. Most important is 3 a.m. So what is the answer? Is it dawn phenomena or Somogoi phenomena in the patient? Tell me the answer. Is it dawn phenomena or is it Somogoi phenomena? Yes, 3 a.m. hyperglycemia is there, hypo is there, and early morning hyperglycemia. Of course, it is Somogoi phenomena. Of course, isn't it? Because in the dawn phenomena, both time there will be hyperglycemia. Now, what should be the treatment of choice? Increase morning. Yes, Ahmed, why dawn? In the dawn, see, in the dawn phenomena, at 3 a.m. hyperglycemia, in early morning hyperglycemia, in Somogoi phenomena, okay, early morning will be hyper, but at 3 a.m. there is hypo. So this is what? Somogoi phenomena. Now, the patient is having hypoglycemia, what should you do? Increase morning NPH, decrease evening NPH, decrease morning NPH, decrease evening regular insulin, change regimen to glargine at bedtime and continue morning, discontinue both, or change regimen to glargine at bedtime with lispro to each meal. What is the correct answer? Tell me. The patient is taking short-term insulin and intermediate acting insulin, and he is having hypoglycemia at 3 a.m. What is the best change in the treatment regimen? Just tell me the answer. What do you think should be the best treatment regime? Why patient is having, hypoglycemia? Because they're taking short term insulin. Yes, medical student, answer E. Wonderful. Very good. Absolutely correct. Your answer is yes, change regime to glargine. Glargine is the peakless insulin. T half is 24 hour. Okay. So it is best. With Lispro is short acting. So before meal you can give short acting. Before meal. But at night, okay, you can give at bedtime glargine, determinine, all those. So answer is absolutely E. You are correct, my student. So this was about the very basic of physiology in diabetes and bit of clinical. So thank you everyone. If you have any question, you can ask me. You can ask me any question if you have. The time was very less, so it was very concise. Very concise. It was a too short description of diabetes in the form of integrated. Okay. So thank you for joining me. Thanks a lot. For any questions, you are most welcome. You can download Doctoral app and you can see there also. You can ask me there also. You can join Telegram channel for DocTutorials. And any doubt, you are most welcome. Till then, bye bye. Good night. Take care.